to 7.
3 minutes. Are you ready to start?
Yeah, 1 minute.
1 minute. 1 minute. Okay.
There are almost 50 participants online in this now. It doesn't include the YouTube and FaceTime,
Oh, that's
Facebook.
nice. That's
A lot of
nice.
people.
We have
we have-
50 in Zoom platform, and the YouTube now, we have about 30 people waiting for the
And here at the Zoom platform, we have most of the main people, the chief of departments of cardiovascular surgery of the country. At least the largest centers are all represented here. I can see Luciano Albuquerque, that you know you very, very well also.
That's
And
great.
yeah, many
Hi, Dr.
people.
Coselli.
Hey,
Hey,
Luciano, how are you doing? Good to see you.
well, the same. How about Kelly, Catherine, Joe Jr.? Everything is fine?
They're all good. They're all good.
Good.
Everybody's
Good.
healthy.
I'm glad that.
Okay,
Very good.
7 o'clock. Vanderlei, can we begin the section?
So I'm going to go to share screen, okay?
Okay. Dr. Coselli, on behalf of the Brazilian Academy of Cardiovascular Surgery, I want to thank you for your participation in this section. Your prominent presence in cardiovascular surgery, especially in the treatment of disease of the aorta, greatly enhanced this section on the Academy. Once again, thank you very, very much for your participation. And now I will turn the conference over the president of the Academia, Dr. José Vanderlei Neto. Please, Dr. Vanderlei. Where is Dr. Vanderlei?
Open your microphone, Vanderlei. Open your microphone.
Liga o microfone, Vanderlei.
Então, boa noite a todos. O Paulo Brofman já fez os agradecimentos ao professor Coselli, que é uma lenda na cirurgia cardiovascular, e nós combinamos aqui, professor Coselli, que o professor Enio Búfalo, que é um considerado o pai da moderna cirurgia aórtica aqui no Brasil, ele vai fazer uma breve apresentação sobre o senhor. Traduz aí, Paulo. E depois o Paulo vai coordenar as perguntas que vão ter. Nós estamos em 2 plataformas aqui, na Zoom, com 67 participantes, e na outra, no YouTube, nós temos 38 participantes. Então, é uma boa plateia e tenho certeza que nós vamos ter uma aula memorável para conhecer essa história épica da cirurgia da aorta no mundo. Enio, você com a palavra.
Okay. It's an extraordinary pleasure for the Brazilian Academy of Cardiovascular Surgery to have Dr. Joseph Stapleton Coselli among us in this special meeting. Dr. Coselli has been with us in Brazil in many scientific occasions and made a lot of admirers and friends that are present now in this audience. It's very difficult to describe the extraordinary career of Dr. Coselli and summarize. It's fair to say that he firmly stands tall among the great cardiac surgeons emerging from the shadows of Texas greats, like the Baker, Cooley, and Crawford. Dr. Coselli started very soon in cardiac surgery. He met Dr. Denton Cooley for the first time in Houston and was assigned to the pump team of Charlie Reed. And that time, it was president of the American Board of Cardiovascular Perfusion. Seeing Dr. Cooley operating an aortic arch aneurysm, he decided to be a cardiac surgeon, and since then, never looked back. Dr. Coselli graduated from the George Strait Jesuit College and moved to the University of Notre Dame. The medical school was in the University of Texas Medical School branch in Galveston, and the residence in general, and after that in thoracic surgery, was made in the well-known service of Dr. Michael DeBakey at the Baylor College of Medicine and affiliated hospitals. As an upper-level resident, you worked on the service of Dr. Stanley Crawford at the Methodist Hospital, and with his hand on Coselli's shoulder, Crawford altered the trajectory of Coselli's surgical career. In '84, Coselli became a junior associate of Dr. Crawford, and he matured clinically and academically. On January 91, Dr. Crawford suffered a debilitating stroke, and with the Baker's approval, Coselli and Hazen Safi split Crawford's service. After that, Safi changed the institution, leaving Coselli to run Crawford's service on his own. The hard work led to top positions, like professor and vice chair of the Division of Cardiothoracic Surgery at Baylor College of Medicine, chief of adult cardiac surgery at Texas Heart Institute, and chief of adult cardiac section at Baylor St. Luke's Medical Career. Regarding a metrics overview of the scientific production, he wrote 257 papers, leading to an extraordinary 15,494 citations in 9,697 papers. His H index is outstanding, is 6.7. The main topics of the publications were thoracoabdominal aneurysms, deep hypothermic circulatory arrest, dissecting aneurysms, and cerebrospinal drainage to prevent paraplegia. The number of honors and awards are many, and I will not nominate, but a lot of them related to excellence in research. The activity in medical societies are remarkable. Past president of EATS, past president of Michael DeBakey International Surgical Society, past president of Denton-Kulik Surgical Society, past president of Texas Surgical Society, director of the AATS Foundation, director of the American Board of Thoracic Surgery, and member of important societies like European Society of Cardiothoracic Surgery, Society of Thoracic Surgery, American College of College, American Heart Association, American College of Chest Physicians, among others. In his presidential address at the ATS in Baltimore, Coselli expressed gratitude to his mentors, DeBakey, Cooley, and Crawford, and stressed the benefits of competition regarding progresses in all fields of medicine. I have to recognize that it's very difficult to describe the contribution of Dr. Coselli to cardiac surgery. What I presented this evening is only a small part of a brilliant medical career. Dear friends of the Academy, we will have this evening the history of the aortic surgery described to us by an international opinion maker that participated as an actor in all phases of the extraordinary progress of this field. And more than that, lived in the temple of surgical treatment of aortic disease. Dr. Coselli, thank you very much in advance for this conference and for your friendship. We are sure that the audience will appreciate an outstanding lecture. Thank you very much.
Shall we begin?
Yes.
Can you see my slide?
Yes.
Okay. Well, thank you. Professor Brofman and Wanderley, Appreciate your comments very, very much. It's an honor for me to have the opportunity to address the Brazilian Academy for Cardiovascular Surgery. And I'm going to talk about the history of aortic surgery. It's a long story. It's a complicated story. It has a lot of twists and turns, and there's quite a few overlaps and many things developing parallel to each other. So it's not going to be a straight line that I describe, but most of what I'm going to talk about is going to actually be of historical interest rather than the current status of things. These are some of my disclosures. And my friend, Dr. Buffalo, thank you so much for that terrific introduction. I have been honored to be your friend for many years and have been always very, very impressed by your contributions to cardiovascular surgery. You're one of the amazing leaders, and your words tonight to me are more than I can express. So why history? Well, you know, they talk about if we may have to repeat it if we don't know it, but for many of us, we learn from history so that we can put the advances that we make currently and in the future in some perspective. Pertinent to the current situation with COVID, the picture in the right upper corner of this particular slide is actually from the pandemic from 1918. This is a quote from Confucius on this subject. Our greatest glory is not in our failing, but in our rising every time that we fall. And I think the history of aortic surgery is one of making efforts and not always being successful, but continuing and persisting towards trying to do the right thing and making continuous efforts towards improvement. And on this subject, this is a interesting quote. It's a little bit long, but I think it's worth looking at. It's from a speech from the Sorbonne. It is not the critic who counts. It's not the man who points out how the strong man stumbles, or where the doer of deeds could have been done them better. The credit belongs really to the man who is actually in the arena, whose face is marred by dust and sweat and blood, and who strives valiantly, who errs and who comes short again and again, because there's no effort without error and shortcoming, but who does actually strive to do the deeds, who at the best knows that in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who neither know victory nor defeat. And I think that describes the history of aortic surgery a great deal. I have to tell you that I absolutely love the country of Brazil. I've had the privilege and honor of being there many times, and I cannot tell you how much I've enjoyed every single one of them. These are just a few recent ones: 2015, 2017, 2018, more recently in 2019 in Guyana, where actually they make some of the smallest hamburgers, I think, anywhere on earth. The history of aortic surgery worldwide, there's been many, many contributions who've come out of Brazil. These two gentlemen are just a couple of them. Professor Luiz Egard, I'm not going to pronounce it well, Pechileao, the first to use synthetic aortic grafts in Brazil, and Professor Degani, the founder of the Brazilian Society of Angiology, all the way back in 1951. Although Professor Buffalo's comments were very kind and extensive, you might question, well, you know, why me talk about this? Well, I came to Baylor in 1977, and I've been at Baylor for training and on the faculty ever since. And much of the history of aortic surgery has taken place actually at Baylor College of Medicine and in the Methodist and St. Luke's Hospital. DeBakey came to Baylor in 1948, then Cooley, a native Houstonian, came in 1951. Dr. DeBakey was actually from Louisiana, had worked with Alton Ochsner in New Orleans and spent some time overseas studying with Lariche Kirshner. But after the war, when he came back to New Orleans, an opportunity opened up at Baylor, and Dr. DeBakey came and really started the medical school there as president of the school and head of surgery. He recruited Dr. Cooley from Johns Hopkins University in 1951. He was a native Houstonian who wanted to come back to Texas, and he had spent some time studying with Blaylock and Lord Brock. Dr. Crawford, who grew up in a small town in Alabama, basically with dirt roads, ultimately ended up training at the Massachusetts General Hospital under Churchill and Allen. He spent a year as a fellow under Dr. DeBakey and went back to the Massachusetts General Hospital to finish his training. And at the completion of his training, Dr. Crawford recruited him to join his faculty in 1954.
Melhor cirurgião da aorta.
I've had the honor and pleasure to know and work with all of these gentlemen, Dr. DeBakey and I, many years ago. Interestingly, Carlos Jose de Brito, another famous surgeon from Brazil and editor of his textbook, requested a fellowship with Dr. DeBakey in 1965, trained in Houston, and went back to Brazil and helped to spread aortic surgery throughout the country. And he advanced many, many techniques. And in fact, Stanley Crawford in 1981 visited Brazil, and Dr. De Brito hosted him at the Brazilian Angiology Conference. I've known Dr. Cooley because we're both native Houstonians, and we've just known each other for many, many years. I got to know him in high school and in my college years, and he has been a mentor and a foster of my career for many, many years. Dr. Zabrini, another famous surgeon in Brazil, gave Dr. Cooley several tours beginning all the way back to 1959. And Dr. Zabrini is responsible for developing Brazil really as a cardiovascular powerhouse. He aided in the development of early cardiopulmonary bypass machines in Brazil and promoted their use throughout the country. Responsible for the first heart transplant in Latin America in 1968, and demonstrated and taught so many surgeons and fellows throughout the years, and founded the SBCCV in 1970. My relationship with Dr. DeBakey was one that was very professional and very cordial. And Dr. DeBakey and I worked side by side for many, many years, and he was a mentor. Despite the great age difference, I think we were friends. My relationship with Dr. Cooley, shown here on a hunting trip for quail in South Texas, was a little different. We traveled together and had many, many good times together. When I finished my training, I joined the faculty at Baylor and spent 7 years working side by side clinically and with research and publications, et cetera, with the famed cardiovascular surgeon, Dr. E. Stanley Crawford, who, as I mentioned before, went to Massachusetts General Hospital after he left Alabama and then came to Houston for the opportunity there. You can't really talk about cardiovascular surgery without talking about circulatory support. Dr. John Gibbon is on the right, and the rotary pump is in the middle. A lot of work in a lot of different institutions was going on simultaneously. Gibbon in Philadelphia, working with IBM and others, Dodrell in Detroit, Mustard, of course, in Toronto. All these gentlemen were trying to develop a machine that would replace the cardiopulmonary support so that open heart surgery could finally be carried out basically in the way that we know it now. Dr. DeBakey was responsible for working with some engineers at Tulane, where he modified the rotary pump. The problem with the rotary pump up to that point was that when you put tubing in there, the tubing would creep, it would march along. And he and a compadre of his modified the rotary pump so that it would be useful for cardiopulmonary bypass. He met John Gibbon at a meeting. John Gibbon was working on his machine, and Dr. DeBakey had examples of his pump there. And Dr. DeBakey, in a number of his publications and interviews, gave John Gibbon credit for immediately recognizing that the rotary pump would be a solution for some of the issues with the cardiopulmonary bypass machine, and it's still used today. On the right is a picture of Mary Gibbon, Dr. Churchill, and Dr. DeBakey in the middle, when Dr. DeBakey was receiving the Gibbon Award for his efforts for this. But to really do something about the aorta, and you're going to have to forgive me, I'm going to move around in my discussion a little bit and then try to pull everything together. But except for the abdominal aorta, where in thin patients you can actually palpate the abdominal aorta in many cases, to really have an opportunity to treat the pathology of the aorta, what we need to be able to image the aorta. And the thing that really allowed us to study the entire aorta in a non-invasive way was finally the development of CT scanning. The gentleman that invented CT scanning received the Nobel Prize for it, but it was Axel Baum in 1976 who, in 30 patients, and you can imagine the scans were at 2-centimeter intervals, was able to recognize that aortic pathology could be imaged this way, initially at high cost, but now, as you well know, CT scans are they're pretty much everywhere. And they allow us to evaluate the entire aorta in a non-invasive way and study the pathology of the aorta in ways that were just simply not available before. Before I get too much further on it, Dr. Filipposi was a pioneer in cardiopulmonary bypass in Brazil, and was responsible for a cardiopulmonary bypass machine with the roller pump using the K-cross type disc oxygenator at first, and that allowed for some of the first surgery for total cardiopulmonary bypass in Brazil. Jose dos Santos Perfeito was the first perfusionist in Brazil, and one of the models for the cardiopulmonary bypass was built in the workshops of the Sabado de Angelo Heart Institute and from 1956, and you can see him with one of these very, very early machines. And the first heart surgery for cardiopulmonary bypass in Brazil, in this report by Walter Gomes, Saba, and Dr. Buffalo, was carried out in November of 1956 using some of these very, very early cardiopulmonary bypass machines. Now, in the mid-1950s, there really wasn't a reasonable treatment for aortic aneurysms, and the most common of which were identifiable, were infrarenal abdominal aortic aneurysms. And I'm not going to go into detail on this, but in the mid-1950s, in this report was articulated by Ditakas, the three techniques that were available and recognized were injecting wires inside the abdominal aorta with and without electricity, wrapping the aorta, usually with cellophane, and the wrapping generally wasn't the circumferential wrapping. It was more often just the anterior surface back into the retroperitoneum, with the idea to develop the cellophane would promote sickerization and scarring and hold the aneurysm in. This is the technique that was used on Einstein, and then he lived for 7 years before his aneurysm ruptured. And then, of course, the treatment of ligation, which had been around for many, many years, but met with a great deal of failure. So to do something about aortic pathology, we had to replace it with something. The first of which was homograph. Homograph, which was fresh, homograph, which was freeze-dried, multiple different techniques. And you can see on the right-hand side where it's been used to replace the infrarenal abdominal aorta. And this was done by DeBost in a patient who'd lived for 8 years. But homographs were used to replace the abdominal aorta with Dr. Cooley and Dr. DeBakey in really large numbers. In 1952, they reported survival of 6 out of 7 patients, but rapidly were operating on hundreds of patients. It was used to replace the descending thoracic aorta, and here to report by Cooley and DeBakey, the distal aorta, distal transverse aortic arch, and in this paper, homograph was used to replace the descending thoracic or upper thoracoabdominal aorta, and Dr. DeBakey and Cooley reported the first successful homograph replacement in a series of 5 patients, 2 of whom lived. So that was actually a remarkable accomplishment in its day, using the homograph to replace ruptured abdominal aortic aneurysms. And then finally, a few years later, with the use of cardiopulmonary bypass, a homograph to replace the ascending aorta. And then the coup de grace was using an Invalos sponge to create a temporary bypass and then replace the thoracoabdominal aorta, again now with homographs. Homographs have their problems. They had limited availability. They were prone to calcification, in some cases to dilatation. The first synthetic treatment of an abdominal aortic aneurysms was by Voorhees in 1952 using Vignan-N. They had been using Vignan-N in dogs in their laboratory, and they had an aneurysm that was leaking or rupturing in New York, and they cross-clamped the aorta, and then were surprised to find that they had no homograph to replace it. So they went down to the laboratory and pulled some plastic cloth, this Vignan-N, and used it to replace an abdominal aortic aneurysm for the first time. But the real practical material was developed by Dr. Michael DeBakey, and he used it for the first time in 1954. It was used initially in a tubular form and in a bifurcation form. It was a woven material, but later it was developed into having knits, a knitted material, etc., and has been the mainstay of aortic replacement ever since. This is actually a picture of the some of the first Dacron tubes that Dr. DeBakey had made on his sewing machine. Hope you can listen to this.
May wish to see the kind of Dacron graft we use. This is one of our own design, and this is what we use routinely now, as you can see. It's made out of Dacron, and it's specially made for this purpose. And in time, it's replaced by normal tissue, so that we know from past experience that this really becomes a very good substitute for the artery.
Well, it's an excellent material to replace the aorta, but I think he was slightly mistaken in the way he said that it was replaced by the patient and dissolved. It retains as permanent material. Dr. Cooley was a chief resident with Blaylock, as you can see here in this picture up on the left-hand side, with Blaylock on the suit in the middle, and Dr. Cooley was part of Blaylock's Blue Baby operation. He and Blaylock became very good friends. Dr. Cooley was playing tennis, and Dr. Blaylock walked by and noticed that he was playing tennis. And Dr. Blaylock had a second home on the water and loved to play table tennis, and invited Dr. Cooley to come spend the weekend at his second home and play table tennis and have a few adult cocktails together. And they became good friends as a consequence. And that led to Dr. Cooley in the picture on the right being in Blaylock's Blue Baby operation. The first collaborative report by Dr. Cooley and DeBakey was on replacement of the transverse aortic arch, primarily placing a partial occluding clamp and then removing the saccular aneurysm and then oversewing it. And they reported on 6 cases together, 5 of which had syphilis. And here's what he had to say about it. Thank you.
One of the seminal articles on aortic aneurysm was published in 1951 by myself and Dr. DeBakey. In that seminal article, which inspired a lot of surgeons to get involved with aggressive treatment of aortic aneurysms, 3 of the 6 cases were done during my residency years at Johns Hopkins.
The first case Dr. Cooley did, Dr. Blaylock was out of town and came back and was surprised. He thought the patient was inoperable, and he remarked later that the one way to manage an inoperable patient is to leave town and have your senior resident take care of it while you're gone. Dr. Cooley went on in 1961 and 62 to form the Texas Heart Institute. He spent 18 years on the faculty working side by side with Dr. DeBakey. But this is in 1982 after they had split up. And this is a typical day schedule for the Texas Heart Institute with 46 cases, 24 of which were coronary bypasses, 5 valves, 5 congenital cases, 2 aneurysms, and a variety of other procedures. In 1962, shortly after they established the Texas Heart Institute, this is the number of individuals, the type of thing that was going on in the operating room. It was very exciting, lots of visitors. This would be impossible today with the risk of infection. Dr. DeBakey and Dr. Cooley split. We've talked about this before, but in April 4th of 1969, Dr. Cooley had a patient by the name of Haskell Karp who had a ventricular aneurysm, severe coronary artery disease, many myocardial infarctions, poor ejection fraction, and he couldn't get him off pump after he did the the ventricular aneurysm repair. So he went down into the laboratory and pulled out the total artificial heart and placed it in Mr. Karp. This was the first time this had been done in a human, and it created quite a news storm. This is a picture of that heart inside Mr. Karp. The device, when it was later removed, is now in the Smithsonian Institution. This is some of the newspaper articles that appeared at the time. It was quite an international sensation. Dr. DeBakey was out of town at the time and was not pleased. He thought that his work on the artificial heart had been with Dr. DeBakey and was very unhappy about it. And as a consequence, these 2 gentlemen developed what known as a bitter feud. They didn't speak to each other for about 4 decades. We should have known that they were going to have problems early on. This is a picture of the early 1950s of Dr. DeBakey's Department of Surgery. You can see Dr. DeBakey in the lower right-hand side. Arthur Bell is in the dark suit in between, and then Dr. Cooley is to the left. You can see they had a difference in their ties that they wore at the time, and so we should have been alerted to the fact that they might end up with some differences. As I mentioned, they both became very, very famous surgeons in their own right. Speaking to each one of them, they both attributed their so-called feud and the competition of these 2 great surgeons in hospitals side by side, that this competition actually spurred them on to do greater things than maybe they would have if they had just continued to work together.
Now that you have the heart actually made up, how much do you think an individual heart would cost now to make?
This is difficult to estimate. Once you have the facilities for making them, I suppose that we could have one of these devices, which is the disposable part of the device, for around $3,500 or something in that range. There are about $1,500 worth of valves inside, and that, of course, is just one of the components. But all this all these additional components, the materials cost something, but the fabrication is.
imagine 4 valves at the cost of
At the
$1,500.
present time, there doesn't seem to be much justification, and certainly for the first case, in trying to do the artificial heart as a technique in itself. Therefore, it seems to me that the use of the artificial heart was justified because of the experience we'd had in cardiac transplantation. In other words, we had a backup, a second stage that we could use, which would provide hopefully for 6 to 12 months and possibly longer. So it seems to me this all fits into some sort of an evolutionary process. We had to have the cardiac transplantation first, and then give us a chance to use the mechanical devices. I'm not sure whether one should let someone die in the operating room without taking another chance at prolonging his life by using a mechanical device.
Was Dr. Cooley being very prescient talking about using artificial hearts and later LVADs for a bridge to transplant, and then even thinking further ahead as artificial hearts and LVADs being used for destination therapy. Fortunately, their feud ended and they became friends towards the end after Dr. DeBakey had his own ascending aorta replaced for aortic dissection. So we'll go back to the history of things. Things really couldn't happen the way they have for cardiovascular surgery without the work of Carrel and his assistant Guthrie. And for this, Dr. Carrel won the Nobel Prize, I believe, in 1911. And the Nobel Prize was specifically for the vascular anastomosis that's so important in all of the cardiovascular work that we do. And going back to the fact that we have to image things, I mentioned the CT scan earlier because it's just so important as a ubiquitous tool in small hospitals and emergency rooms in all of our countries where the entire aorta can be visualized and pathology be identified for treatment and focused upon. But all of this couldn't have happened without the radiology with Ronaldo Santos in Portugal, and of course, Rentgen with X-ray and everything, and before that. Dos Santos is really one of the forerunners of the work for aortography. But in 1923, Berberich, using strontium bromide, carried out really the first, what we think of as an arteriogram or an aortogram at Mount Sinai in New York. Peripheral arteriography had been carried out by Capote using a different material a number of years before, and Dos Santos had carried out a few years later translumbar aortography. When I was a resident, I learned to learned how to perform translumbar aortography because we at that time hadn't begun to use the Sellinger technique in all of our cases, and we would use direct sticks for the carotid arteries, the femoral arteries, and translumbar aortograms. But as I mentioned, it's really CT scanning which has made all the difference. And as I mentioned before, that Sir Godfrey Hounsfield and Alan Cormack, Hounsfield from the UK and Cormack from South Africa, and also came to the US, received in 1979 the Nobel Prize for their invention of the CT scanner, which has so many different uses. Hounsfield was actually knighted in 1981, primarily for this effort. And also, as I mentioned before, just talking about Dr. DeBakey, the importance of that we had to have something to replace the aorta other than homografts. First, it was Vignon N. Ultimately, it was dominated by Dacron, but that's not to say that the journey was a smooth trip. Nylon tubes were used, Orlon, Invalon sponge, even taffeta, plastic dipped Orlon tubes were used, nylon taffeta, a variety of materials with and without the crimps that are so helpful in making curves. But fortunately, we settled on the Dacron, which became so important. And shown here in this picture of a thoracoabdominal aortic replacement with Dacron in one of Dr. DeBakey's very, very early periods. But just to point out that we still don't have the ideal vascular prosthesis, and there's still room for more work there, but it does need to be easily sutured, easily available in wide ranges of sizes and lengths, needs to be biocompatible, hopefully with a low infection rate, and durable to fit the lifespan of a patient. When you operate on a patient with Marfan syndrome who may be in their teens or 20s, for the replacement of the aorta may need to last 50 or 60 years, we would hope, as well as being non-thrombogenic.
The tube is cut to the approximate desired length. Blood is withdrawn into a syringe and applied to the graft. The graft is immersed in the blood, stretched, and compressed to permit fibrin to become entrapped in the interstices.
As many of you know, when grafts were first available, knitted grafts were used primarily below the renal arteries and woven grafts used above. These grafts were not sealed with gelatin or albumin and materials that we have now. I fortunately had an opportunity to work with Dr. Stanley Crawford on the clinical trial for one of these grafts, the Medox graft. But before that, we had to seal the graft. So what was shown here is is very similar to what Dr. DeBakey would do, although this was from the Texas Heart Institute, and that is to take blood before heparinization directly out of the aortic aneurysm and then use that to seal the graft. Later, what we would do would just coat the graft with albumin, then autoclave it for 2 or 3 minutes, and that would seal the graft. But let's talk about the aortic root for a minute. To do something about the aortic root, you have to have the aortic valve. This is sort of a timeline for the aortic valve from 1952 to Al Starr with the cage ball valve, finally in 1962, where we had a replacement for the aortic valve, which was practical, durable, and was a valve that was functionally appropriate. This is Al Starr in the report from 1964, one of the very early cage ball valves that he used from 1962. This went through multiple iterations and actually was an excellent valve. And many of these valves lasted many, many years. We still remove an occasional ball valve out, although not recently, but when patients that had an aortic valve replacement later developed an aneurysm, when we would take in order to do a full root replacement, we'd have to take these out. These valves worked very, very well for a long time. Wheat then came up with a concept of replacing the aortic valve and most of the aortic root for an operation known as the Wheat procedure, to replace almost the entire root all the way up to the innominate artery for aneurysm and aortic dissection. He was a fantastic surgeon in Florida and reported this Wheat operation in 1964. We also recognize that if you replace the aortic valve and replace the ascending tube graft, particularly in patients with connective tissue disorders, most of whom had Marfan syndrome, that the sinus segment would enlarge in between, and we needed a full replacement of the aortic root. This was finally solved with Hugh Bentall and Anthony DeBono in this very, very simple report in the journal Thorax in 1968. It's only 2 pages. It has one photograph, 2 pictures. And if you look in the very lower right-hand side, there's only one reference in this entire article, which is basically a case report. And it's a report by Cooley and Bloodwell, Arthur Bell, Grady Holman, and Michael DeBakey. This is back when Cooley and DeBakey were working together with each other. About 2 weeks before Dr. Cooley died, I was talking to him in his home, and he lamented about the fact that he never had, and he told me this, he was sad about the fact that he never had an operation. There's no Cooley operation. No operation was actually named after him, like the Jettine operation or the Bentall operation, and we'll go over some others here in a minute. And I think when he was telling me that, he was thinking back about this particular paper with this particular reference, and that with one operation and one single case report, everybody calls this the Bentall operation ever since, but there was never really a Cooley operation. Dr. Kachukas modified it by, instead of, once we had grafts that were sealed and weren't going to leak through them so well, that you didn't have to wrap necessarily the aortic wall around the repair, that you could actually remove the aneurysm and reattach the coronary arteries, which could be mobilized for a short distance, which reduced the risk of bleeding inside the wrap as we used to do, and that the coronary arteries pseudoaneurysms wouldn't develop because they were mobilized and not under tension. And then another famous heart surgeon, Dr. Tyrone David, out of Toronto, from another gentleman from Brazil that's made really huge contributions to cardiovascular surgery with his aortic valve sparing operation. This is an operation which has become really ubiquitous, particularly for Marfan patients and for so many other patients where the leaflets are intact, but you have an aneurysm to deal with. You can replace the aneurysm, spare the leaflets, and provide the patient an operation that's hemodynamically excellent, but that they don't have to take Coumadin. He took this as a modification off of the Yakub operation, which was a modification of the Weed operation. But Dr. Tyrone David has become famous for this David operation. And when Dr. Cooley was thinking about an operation not being named after him, I think the two things he was thinking about was the Bentel operation and the David operation. Of course, the other operation, which is becoming more popular again, is the Ross operation, which is the pulmonary autograft placed in the aortic root position and a homograph used then to replace the pulmonary valve and pulmonary artery. And good Lord, these are the two that are available in the United States, but the plethora of multiple valves that can be used to replace the aortic valve. And we're in clinical trials with the mitral valve, the tricuspid valve. The valve surgery has changed so dramatically over the years. And I mentioned Jatin earlier. This is a tribute to him and his life's work. And he's known for the Jatin operation, for the switch operation that has been so valuable for so many children born with this particular congenital defect over so many years. So let's talk about the aortic arch for a minute. The brain is only about 2% of the total body weight, but it uses 15% of the total cardiac output, 20% of the oxygen, and 25% of the body glucose. It has no energy reserves. The energy, of course, is from ATP, and you get aerobic glycolysis, but the nutrition for the brain has to be replenished in a real-time basis because it has no energy reserves, as you know. And if more than 4 or 5 minutes go by without nutrient supply to the brain, then of course the neurons in the brain die and you end up with stroke. This was initially taken on with hypothermia. This is a perfusionless deep hypothermia with an ice helmet in Russia. This is a picture that I borrowed from Dr. Bavaria, but it's from a report in the Journal of Cardiovascular Surgery in 1994, where this technique was used in 3,141 patients in Russia. When I was a student and was at the Texas Heart Institute, I saw very, very similar cases to this technique used on children treated by Dr. Cooley.
While the aorta itself was cross-clamped. Further protection of the central nervous system was provided by means of artificially induced hypothermia. Hypothermia, by reducing the metabolic rate, lowers the oxygen requirements and thus prolongs the critical period of tolerance of the central nervous system to temporary interruption of arterial supply. In this case, body temperature was lowered from 98 degrees to 91 degrees Fahrenheit under.
We're not going to go on further with the operation, but just to show you that this is a technique that they used at the Texas Heart Institute prior to all of the congenital surgery being moved to the Texas Children's Hospital. And Dr. Cooley was a major individual in congenital heart surgery at the time. So the next major development was the use of a heat exchanger, and then using hypothermia and then rewarming the patient without having to do what I just described with all of that ice. Dr. Randy Greep popularized this while he was at Stanford Hospital in California. And amazingly, this was only done on 4 patients, became a landmark paper, became the mainstay of arch repair for 40 years. And it was only 4 patients with 3 survivors. He took it down to very low temperatures, an esophageal temperature of 14 degrees centigrade. Dr. Crawford, in his work on the transverse aortic arch, found that there were limits to what you could do with hypothermia alone, that after 40 minutes, the stroke rate increased, and after 65 minutes, we had an increase in mortality rate. But in operating on 600 plus patients using these techniques of just pure hypothermic circulatory arrest, we had 7% strokes and 10% mortality rate. The concept about the limitations of even deep hypothermia were reported in this paper by McCullough in the Annals of Thoracic Surgery in 1999. And the point of this is even at very, very low temperatures, using a 15-degree centigrade temperature, that the oxygen use was still 16%. And the conclusion of that was that safe circulatory arrest, pure circulatory arrest at these low temperatures was limited to somewhere between 30 and 45 minutes. Now, Mills and Ochsner used retrograde cerebral perfusion for a massive air embolism and reported that in 1980. And then Jerry Lamole reported in 1982 using intermittent retrograde cerebral perfusion, in part, not so much for air, but for cerebral protection. But it was Ueda in Japan who really popularized, in his report in 1988, retrograde cerebral perfusion for cerebral protection during transverse aortic arch repair. Dr. DeBakey in 1957, in his first arch repair, used antegrade cerebral perfusion. They abandoned that primarily because they couldn't control the pressures and the flows with the machinery that they had in the time, and they had too much cerebral edema and too many strokes from not being able to control the pressure and the flow. Frist used it in 1986 in 10 patients, and then Bachet and then Kasui and others really popularized the use of antegrade cerebral perfusion for arch repair. So if you look at the picture on the left, that's DeBakey's first arch repair in 1957 using antegrade perfusion. Frist in 1986 in 10 patients successfully, and then Bachet in 1991 showing his technique there on the right. The other developments that helped us with arch repair and aortic dissection were alternative cannulation sites. Initially, cannulation was in the femoral artery, which in one of the very, very early reports had a stroke rate of at least 3%, just based on that technique. But Sabik in 1995 described in the Journal of Thoracic Cardiovascular Surgery using the axillary artery technique for cannulation for perfusion. And this was described in 35 patients. He only had four deaths and no strokes. 19 of them had arch repair, and 8 of them had aortic dissection. And this became a very, very important technique, particularly for patients with aortic dissection. But we now, dependent upon the pathology that we're treating, will cannulate a variety of different approaches. The femoral artery, axillary artery, one of our preferred approaches over the last 6 to 8 years has been the innominate artery. Of course, the left common carotid, we still use direct aortic on occasions, subclavian, and even transapical, has been described and has been used. The other thing that we use with some frequency is this debranching approach to replacement of the brachiocephalic vessels for arch repair. Was described by David Spielvogel working with Randall Greep. He described it on a number of cases. And you can see in the drawings here how you can reattach and debranch the innominate left common carotid and left subclavian arteries, repair the arch, and then reattach it. And this can be combined with the perfusion technique for cerebral protection. Scott Lemire reported on 55 of our cases using the Spielvogel technique with a hypothermic temperature of 22 degrees. We had no deaths in the hospital, one 30-day death. We had 2 minor strokes and 1 transient ischemic attack. And 85% of these patients had total arch replacements with an elephant trunk repair. So these were all big operations. Let's talk about the elephant trunk for a second. Hans Bors described it for staged repair of extensive aortic disease back in 1983. It's gone through an evolution from his initial reports where the cases were done in 82 and he reported in 83, modified again by Crawford and Svensson. Then the branch graft was added in 2004, and then 2003, the frozen elephant trunk with a stent graft and the descending thoracic component became popular. And now we have devices which can be used to combine this into a single operation. Around the world, there's quite a few elephant trunks and frozen elephant trunks that are available. We've just completed a trial on the Thoraflex device, and this is what it looks like. This is it's looking for, the FDA has all the data and it's looking for approval by the FDA. It's an unsheathing device. We run this over a wire from the femoral artery into the transverse aortic arch. In this particular point in this film, the brachiocephalic vessels are to the left, the heart is to the right. There's the Thoraflex device is placed in the descending thoracic aorta. There's a pull loop that actually unsheaths the endovascular portion of the Thoraflex device. It has a collar to suture to the aorta that's held in this little blue plastic thing, which is removed after you cut one suture. Then the deployment device is removed once the Thoraflex is completely open. We then suture this graft to the descending thoracic aorta, distal to the left subclavian, and then these branches are used to reattach the brachiocephalic vessels. Another technique, if the descending thoracic component is symptomatic and disproportionately large, and you know you're going to come back and do the arch, you can do this reversed elephant trunk, which we reported on many years ago. Here shown where the graft is folded back into the very proximal descending thoracic aorta, then the thoracoabdominal or descending is replaced. You come back through a median sternotomy later, and then you pull the graft back out from within the proximal portion of the descending, and then reattach the brachiocephalic vessels, shown here as an island technique to complete the arch repair. You can use the debranching, as you see that on the right. Dr. Provenza, who works with us, did an analysis of 3,154 patients looking at 35 studies. And the primary focus of this was to look at spinal cord ischemia, but also stroke, operative mortality, and adverse events. But one of the important things that came out of this paper was that we found that these long elephant trunks at the initial operation, those comparing 10 centimeters versus 15 centimeters, that the incidence of spinal cord ischemia and paraplegia when we used a 15 centimeter stent graft, and this is a meta-analysis of 3,000 patients, showed that the incidence of spinal cord ischemia with the longer grafts, 15 centimeters, increased as compared to those patients who had only the 10 centimeter graft. The overall spinal cord rate problem was almost 5%, stroke rate 7.6%, and an 8.8% in these 35 studies which were evaluated. Let's talk about dissection for a minute. The first successful dissection repair was reported in a series of 6 patients by Cooley and DeBakey when they were still working together. Some of these patients were just simply, they divided the aorta, closed the false lumen, and sutured it back together in an end-to-end fashion. But for most of them, they replaced it with a homograph, as you can see in this picture. And this is the 6 patients that were replaced. A couple of these were acute. The rest of them were chronic. And as you can see that there was a good repair in 4 patients, and 2 of the patients died. The first successful type 1 ascending repair was carried out in the Methodist Hospital by George Morris and reported with Dr. DeBakey on a young doctor who was in his 30s, had an acute dissection, and Dr. Morris, what he did was simply divided the aorta, closed the false lumen, and sutured it back together. It was 1962 and a 32-year-old physician, and he lived for many, many, many years. When I was a resident in approximately 1983, Dr. Gerald Lowry and I saw this patient back. He had gone on to develop an aneurysm of his root and ascending aorta and proximal arch, and we reoperated on this patient. Some 50 years later, 20 years later, where where we replaced his valve ascending and hemiarch, and he again did fine. I'm not sure what happened to him many years after that. The classification that Dr. DeBakey came up with evolved over time. On the left-hand side, in 1960, you can see he had a model of 5 different techniques, and ultimately was able to report the 4 types of aortic dissection, the DeBakey classification, a year later, 1961, with 72 patients. And ultimately, this became popularized by his report in 1965 in the Journal of Thoracic and Cardiovascular Surgery on 179 patients, which actually almost 80% of the patients lived. A few years later, in 1970, Daly described in the Annals of Thoracic Surgery the so-called Stanford classification, type A, where it extended throughout the entire aorta, and B, just the descending thoracic aorta, which we're so familiar with. And it's interesting that he described this in a series of only 35 patients, but had great success. As you can see here, the survival rate was quite good. It was always quite interesting what Dr. DeBakey thought about the Stanford classification. And this is a quote from a commentary that he made a number of years later. And he says, in 1966, we reported on some illustrative cases, as I showed you, classified the disease into 3 types with distinct characteristics requiring different surgical procedures. In other words, he focused on the type of dissection and what the surgical treatment might be. Sometime later, the surgeons at Stanford report on their experience and advised modifying our classification by combining type 1 and type 2. This made no sense to me because the 2 types were entirely different and required different surgical approaches. So Dr. Cooley kind of didn't think too much about the Stanford classification, but for all practical purposes, we use both of them. And speaking of dissection, our host, Warren Buffalo, in 70 patients reported on placing a graft in the descending thoracic aorta, going through a median sternotomy and open up the arch. And we thought this was a very, very interesting technique. We never specifically used it for this purpose, but we have used the modification of this technique a lot. In other words, when we do type A aortic dissections and we do a bevel hemiarch, we very, very frequently put an endovascular stent graft in the true lumen down into the descending thoracic aorta, usually a 10 centimeter graft, and then we repair the proximal aorta depending upon what it needs. Dr. Provenza did a report looking on 178 patients that we had treated with a standard repair in 115 of them, and this endograft and the rest of them. And what she found was that the antegrade stent delivery was associated, we had a lower operative mortality, we had better long-term survival, and in the midterm, the promising of the remodeling of the false lumen was seen in stented patients that we didn't see in the non-stented patients. And the midterm survival was actually greater in the stented patients. So there was greater survival. So very quickly, we're going to talk about thoracoabdominal aneurysms. Maybe the first one was done by DeBakey and Cooley in that what was earlier described as a descending. Rob reported 6 cases of the aorta going above the renal arteries in a series of 33 abdominal operations. But it's really Etheridge in 1955 who reported a single case report. It didn't become known as the Etheridge operation, but it was a true thoracoabdominal aneurysm. He sacrificed the left kidney rather, beveled just above the right kidney and reattached the celiac and the SMA, and he used a thoracoabdominal approach, and he used a homograph, and the patient survived. Dr. DeBakey quickly jumped on these thoracoabdominal repairs with homographs, and then, of course, once the Dacron graft was available, it was rapidly used to replace thoracoabdominal aneurysms. Dr. Crawford in the 1970s decided upon a more anatomic technique, working inside the aneurysm like we do abdominal aortic aneurysms, cutting holes in the graft and then reattaching the visceral and renal vessels, and really popularized thoracoabdominal repair. And he's known kind of as the godfather of thoracoabdominal aneurysms. DeBakey reported on 42 thoracoabdominal aneurysms using these homographs and early Dacron grafts with only a 26% mortality rate, which was actually amazing for the time. And even in this report in Time magazine in 1965 shows Dr. DeBakey with these branch grafts replacing the thoracoabdominal aorta. They threw in an arch in the drawing. It's just a hypothetical drawing, of course, but at this time in the 60s, cardiovascular surgeons like Dr. DeBakey and Cooley were becoming rock stars. This is from one of his reports on thoracoabdominal aortic aneurysms with an unbelievable aortogram and drawing 27 years after the thoracoabdominal aneurysm was repaired. This is just some more pictures from the same report. Dr. Crawford latched on to thoracoabdominal aneurysms and reported a series of 23 cases. It added 5 additional cases in the addendum, and he really pushed thoracoabdominal repair to new heights and became very, very well known for it. The mortality rate came from 50% down to 8%. He described the 4 extents of the thoracoabdominal aneurysm that have his name. We talk about these as the Crawford extent 2 aneurysm as being the long one from the left subclavian artery to the aortic bifurcation. This is from a 7-year follow-up arteriogram after one of his cases in one of his early reports. The shed blood was a problem and transfusions were a problem. So Dr. Crawford worked with Dr. Yawn and Lou Feldman at the lab at Baylor and became known as this bowl that was used to take shed blood and spin it down. So it became known as the BRAT, the Baylor Rapid Auto Transfuser. And modifications of this are still used worldwide for many, many operations where there's a lot of bloodshed that can be returned back to the patient. His lifetime experience was 1,509 patients reported under Svensson in 1993, the year after Dr. Crawford passed away. He had a 31-year experience, and the paraplegia rate was 16%, but the extent 2, it was 31%. So we had a lot of paraplegia and paraparesias, particularly in the patients with these long extent 2 aneurysms. But there's no question that he changed the field of thoracoabdominal aortic surgery from the Dr. DeBakey era all the way through what we do today. This is from a report that I made to the AATS a number of years ago and reported it a year later, where we had permanent paraplegia of 3%, in which I did 3,309 patients. Operation was very durable. Out to 15 years, we had 94% of patients did not require any form of reoperation. This is from a similar format, but it's 3,670 open thoracoabdominal aneurysms where we have paraplegia at about 3% and the mortality rate between 5 and 8%. Very quickly, I'm going to talk about the descending thoracic aorta, first reported by DeBakey and Cooley. And for many, many years, this is what we did. We did a thoracotomy, clamped the aorta, sewed in a graft, took about 15 or 20 minutes and closed the aneurysm wall around it. In complicated cases, we might use left heart bypass, as you can see here. Early days, the mortality rate was 15%, but we got this down in the late 80s down to 2% and less for open thoracoabdominal repairs. Nobody does this operation anymore. We use endovascular stent grafts for almost all these descending thoracic aneurysms these days. even in patients with Marfan syndrome, although many of those will go on to later have an open repair. This is Dr. Cooley and I, and this is in 2005. This is the first hybrid, this is the second hybrid suite, I think, in the United States. We were in the DeBakey building, and I had just moved from Methodist to St. Luke's Hospital. And this is the day where the first endovascular stent graft was placed inside a descending thoracic aortic aneurysm by me in the Texas Heart Institute, for the Texas Heart Institute. Obviously, it had been done elsewhere, but this is the first one done at the Texas Heart Institute. And Dr. Cooley came into the room, watched me do that, and we had a good time that day. The world changed, of course, with the Palmaz stent when he reported in 1988 for intraluminal stents for atherosclerotic, particularly the iliac arteries. The first coronary Palmaz stents was placed in a patient by Eduardo Suso in Sao Paulo in 1987. The pilot study in the US started in 1988, and this stenting of arteries really changed the world. Perotti in Argentina used covered stents finally to replace the infrarenal abdominal aorta, popularized all over the world shortly thereafter. Veloto's working in the Ukraine at the same time. They did not know each other existed at that time, but was doing many of the same operations. That this transfemoral intraluminal graft to treat infrarenal abdominal aortic aneurysms, without question, completely changed what we do for aneurysm therapy. This is the first case of endovascular correction of a AAA of a bifurcated graft in Porto Alegre in 1996. And this, again, Buffalo and 70 patients using this in the descending thoracic aorta. Lobato from Brazil brought us the sandwich approach, which still has a great deal of use. And he's made quite a name for himself throughout the world. And this Lobato technique of sandwiching grafts and very, very difficult pathologies does have a place and is used by many. The Vorger is a fenestrated graft in Brazil, and it's an endoprosthesis which can be used to replace the thoracoabdominal aorta. The Braley graft was used actually in Italy and is under clinical trials. This is from the 2020 BJ CVS, Brazilian Academy for Cardiovascular Surgery. What a great time was had in that particular meeting. Can't tell you, I've told you a little bit about a past, a little bit about the present. The future, we know that cardiac surgeons, interventional cardiologists, and radiologists, and vascular surgeons are all going to work very, very closely together, treating aortic pathology. This is an endomental for the aortic root. It's a single case report from Brazilian efforts. Now we replace all of the aorta with endovascular therapies. Marcelo Ferreira, of course, has been one of the pioneers in Brazil in this technique. He's a good friend, and I've visited many times in Rio, and I've used much of his techniques in many of the cases that I've done. Gustavo Odorich is a Brazilian from Porto Alegre who went to the US to train in 1997, initially in Utah. Spent 2 decades of experience in the Mayo Clinic, mentored by Roy Greenberg at the Cleveland Clinic, and has become a world-renowned expert in endovascular thoracoabdominal repair. Over 600 academic publications, edited 3 textbooks, and has made over 700 academic presentations and become world famous, really, for his endovascular reports. Just another Brazilian that's done a fabulous job for cardiovascular surgery. He started out in Porto Alegre and then the Federal University of Rio Grande do Sul. Then he went to Utah. Then he went to the Mayo Clinic, did an advanced fellowship at the Cleveland Clinic, back to the Mayo Clinic, where he stayed for many years, and then finally has landed here in Houston and is the director of advanced endovascular aortic program at the University of Texas Health System here in the Texas Medical Center. And it's just another Brazilian that we're glad to have here in Houston. So the best way to predict the future is to create it across pedal Drucker. So I think we need to continue to push the envelope, not take anything for granted, and think that there's many, many things yet to be done. And as a general sense in what we do and take care of patients every day, from Edmund Pellegrino, who was an ethicist and a physician at Georgetown University, medicine is the most humane of sciences and the most empiric of arts and the most scientific of humanities. And I cannot agree more. One of Dr. Cooley's favorite poems is A Bag of Tools. And I think this is very, very applicable to this particular group of individuals and to the young people listening. Isn't it strange that princes and kings and clowns that caper in sawdust rings and common people like you and me are builders for eternity? Each is given a bag of tools, a shapeless mass, a book of rules, and each must make, ere life is flown, a stumbling block or a stepping stone. Obrigado. I cannot tell you how honored I am to have the opportunity to speak with you and share this with you this evening. I've visited Brazil so many times. Everyone has been a fabulous experience. It's a lovely country. It's been on the forefront of cardiovascular surgery since the inception of cardiovascular surgery. And I can't tell you how honored and pleased I am to have the opportunity to share this with you this evening. Thank you very, very much.
Okay, Dr. Coselli, thank you for our fantastic presentation. Dr. Enio Buffalo, please. Can you turn on your microphone? No, Enio, you turn on your microphone. Okay.
Thank you, Dr. Coselli, the extraordinary and outstanding presentation and the elegant position to tell something of the Brazilian contribution in cardiac surgery. Thank you very much. I think that the lecture of Dr. Coselli is open for discussion, and I would like that the audience would participate. We had, during this presentation, a complete audience with 100 cardiovascular surgeons hearing your presentation. I don't know how much in the YouTube, but of course, it was an outstanding presence. It is open for discussion, the presentation of Dr. Coselli.
I'd like to make a comment.
Ok. Depois eu gostaria de comentar também, Enio.
Okay.
Well, congratulations, Coselli. As expected, it's a superb lecture on the subject. I just mentioned before that I have seen your presentations on the history of aortic surgery. And my comment is how amazing it is that you are able to improve what was already perfect. Thank you very much for your presentation.
Enio, posso?
Thank you.
Please, please. Before, perhaps Dr. Coselli could respond the question of Nordia.
Oh.
Did you hear Dr. Coselli?
Yes, I did. I think for this presentation, what I tried to do was to include more of the really amazing contributions that so many surgeons in Brazil have made to our specialty. I don't have time or to mention all of them and go into great detail of all of their contributions to what they've done over the years. But I tried in this talk to, because of the group of people that I understood was listening, I thought it would be a nice thing to include more of that in this talk, and I think that's what he's referring to. It's many of the same slides, but I also think it's interesting to hear Dr. DeBakey and Dr. Cooley in their own words describe some of the situations that existed in the early days of cardiovascular surgery and the challenges that they faced, despite the fact that they didn't have to deal with the FDA like that we have to deal with today, and They didn't have to deal with IRBs that we have to deal with today. They faced a whole different set of challenges. And you know, one of the things I like to end many of my talks with is that we really think in terms of many of the heroes, the Jatines, the Tyrone Davids, the Buffaloes, the DeBakey's, the Coolies. But I also think that many of the unsung heroes are the patients that allowed these new techniques to be tried upon them that had never been done before, and their families, and the individuals that the non-surgeons that were, I think, some of the heroes involved in the history of this. And of course, the nurses and the anesthesiologists and the perfusionists that helped us through many of these difficult, and still help us through many of these very, very difficult operations that we don't really talk about so much, but they're absolutely critical in what they've contributed and what they do still today in our work in complex aortic surgery.
Dr. Ricardo Lima, please.
Thank you, Enio. Dr. Coselli, first I would like to thank you for agreeing, coming and speak at the session of the Brasileira Academy and Cardiovascular Surgery. And we are very honored for that. Also, I'd like to congratulate you for the excellent lecture on surgical treatment of the aorta. My question is, traditional open aortic surgery has had a major development in recent years. There was also a great development in the treatment of the aorta via transcatheter. How do you look at the future of an open aortic surgery and or the transcatheter treatment for dissections and aneurysm of the aorta?
Thank you, Ricardo. To answer your question, I think ultimately it's entirely probable that virtually all of the aorta will be able to be replaced with either a very small incision or a puncture with a closure device, both in dissection and non-dissection. The easiest part, of course, initially was the infrarenal aorta, and of course, in the descending thoracic aorta, which was a straight structure and virtually still. The aortic arch and the ascending aorta is a totally different environment. It has a lot of motion in many different directions. It expands, it contracts more, and it moves around a lot more. It's not a very hospitable environment for a rigid device. I think in some ways it's unfortunate, both and also in the thoracoabdominal aorta, the branches, you have some movement, which creates problems with long-term durability. It's I think unfortunate to a certain extent that most companies have tried to take the devices that were so successful in the abdominal aorta and the iliac arteries and the descending thoracic aorta and try to adapt them to the different environment of the ascending and the arch. What they should have done is start with a white sheet of paper and start over, and rather trying to adapt earlier devices to this different environment, to start from scratch and start from the environment and build up something possibly entirely different than what we see today. So we're still in a transition. I think most of the aorta is going to eventually be able to be replaced with endovascular techniques and micro access. The aortic root is probably going to be the last part. We're in trials now with the thoracoabdominal aorta, of course, with the arch aorta, with aortic dissections. Aortic dissections, I think, are going to be type 1 aortic dissections are going to be very, very difficult to treat because of the nature of the pathology and the quality of the aortic tissue in many of these cases. I'll make two more comments. One, we do see failure of endovascular techniques, and we have to go in and do an open operation and remove the device and replace the aorta. So it's still, I've had between 100 and 200 cases where I've had to do that. In our training, when I trained, there were no vascular surgeons per se. General surgeons did peripheral vascular surgery, and cardiovascular surgeons did the other part. And we now have the specialty of specialty training, and we have certificates of training of accomplishment to have a specialty of vascular surgery, and I think that's a great thing. But I find it interesting that when we were training before the days of specific vascular fellowship, we learned to do open infrarenal abdominal aortic operations, and we did a fair number of them. Not a huge number, but a fair number. And about the same number of ruptured aneurysms present today for patients in training. And I guess the point I'm trying to make is for the individual out in the community who can't move the patient to a specialty center and has a situation where his endovascular situation is not amenable to treating a ruptured abdominal aortic aneurysm, we used to take our techniques that we learned in doing open infrarenal abdominal aortic aneurysms and use those with some minor modifications to treat a ruptured infrarenal abdominal aortic aneurysm in an open technique. But now nobody does routine infrarenal open abdominal aortic aneurysms. They're all endovascular. So if you have a ruptured abdominal aortic aneurysm and you don't have the endovascular techniques to do it, you don't have the experience to treat the open rupture. So it's presented some issues in the transition period where we can treat all ruptured abdominal aortic aneurysms in an endovascular fashion. The last piece, and I hate to use too many words, is that some of these cases are going to become infected for whatever reason. A mycotic aneurysm was treated in the first place. It erodes into another structure, such as the lung or the esophagus or the bowel, or they have septicemia and the graft becomes infected. And right now, we're still in a situation where we need to keep some of our open capabilities because these endovascular grafts that become infected, right now, still the best treatment is an open operation, remove it, debride it, and then replace it with clean tissue, clean technique. So one day I think all of this will be treated endovascularly, but we're not quite there yet. We're still in certain areas in transition.
Enio,
Thank you.
Enio, gostaria de fazer uma pergunta, Enio.
Perfect. Por favor. Thank you.
Okay. Dr. Coselli, first I would like to ask you to turn off your slides so we can see each other better.
I'm not sure how to do that exactly.
Oh, yeah? Oh, so keep that way. So
I'm going to try.
Well, this is Casey.
No, how do you stop? There we go. There we go.
Oh, there you go. Fantastic. Congratulations. Congratulations. This is Lucchesi speaking. Well, Dr. Coselli, I saw in the picture of Dr. Cooley with his artificial heart, in his side was Dr. Domingo Liotta. And I have a curiosity. What was the real paper or the real role of Domingo Liotta in the development of the first artificial heart of Cooley's?
That's really a great question. And I had the opportunity to talk to both Dr. Cooley and DeBakey, and they gave me a little bit different story. Liotta was actually the individual in the lab that was doing most of the work on the technical development of the actual physical structure, and was helping putting it in animals. In fact, when Dr. Cooley put the first one in Haskell carp, they really hadn't had a very successful animal study. So it was still very early on. Now, here's what they each told me. Dr. DeBakey told me that it was his device and Dr. Cooley stole it, and that was that. And Dr. DeBakey did have at the time a program that was in part funded by the NIH, the National Institute of Health, and he had the laboratory in his basement at the hospital there, and Leota was working with him, etc. Dr. Cooley told me that he had a separate program that was not with the NIH, but actually was with St. Luke's Hospital and the Rice University. And that actually Dr. Leota was working with both guys, some days at Methodist Hospital and some days over at St. Luke's Hospital, and that it wasn't really Dr. DeBakey's artificial heart that he used on Mr. Haskell Karp, but it was the one that was developed at St. Luke's Hospital in the laboratories. We still have those laboratories in the basement where we have artificial heart work with Bud Frazier, et cetera. So I don't know what the real answer is, but that's what each one of them told me. Dr. Cooley was convinced it was his heart, his device, his research work with Dr. Leota, and Dr. DeBakey thought it was the device from Methodist Hospital, and Leota was involved with both of them.
Oh, okay. Interesting.
Please, Salerno.
So you might be in the Karp's wife. He lived a few days on the artificial heart, then he was transplanted, and then went into multiple organ failure and infection and died about 2 days after his heart transplant.
Okay.
The Haskell Karp family sued Dr. Cooley, and Dr. Cooley actually went to court and he won the case, and it was based primarily on informed consent. And the reason I bring that up was that the case was in 1969, but the court case was in the summer of 1972. And when I was a student, I had a friend that knew that case was going to take place, and Dr. Cooley was going to go to court and actually talk about the case. And I didn't know much. I was a little bit naive about it at the time, but I actually went to the courthouse that day, sat in the courtroom, and watched Dr. Cooley testify on the Haskell Karp case of that transplanted heart. I'll never forget it. It was a fantastic serendipitous opportunity.
Fantastic.
Dr. Salerno, do you want to make some comment?
Peter.
Of course, Dr. Coselli, this was a fabulous, outstanding lecture. It's inspiring to hear you talking. And I have come to realize the reason why you talk so well about this is because you lived it. You contributed to it. You set the record straight on some of the things we always dreamed about. You were humble enough to mention the contribution of others, giving credit to all the other peoples. And your contribution for this specialty is legendary. I'm also very impressed by the affection that you have for the Brazilian cardiac surgeons. I think it's a reciprocal situation. Prior to you coming to present, we have a lot of discussion about Dr. Coselli. We found out quite a bit about you. Very humbly speaking, you're a mentor, an inspiration to anyone, any cardiac surgeon who inspired to be an aortic surgeon. I'm very grateful for you to come to our society, and I wish you all my best, and thank you very much.
Well, thank you, Peter. I've enjoyed my relationship with Brazil for so many years. I'm just looking at the top of my screen where I see the pictures of many of the faces of so many Brazilian surgeons that I've admired for my entire career. And it's been an honor and one of the highlights of my career to know them and to have an opportunity to be in Brazil and to speak to them personally and listen to them talk. And I've learned so much from them over the years. It's been for me, a fantastic relationship that I truly treasure.
Thank you. Paulo, how much minutes we have?
No, we have time, but I don't know if Dr. Coselli have time. But may I say, I want to say something. Dr. Coselli, thank you so much for your fantastic...
Paulo, Neirotti quer falar, Neirotti.
Okay. Okay, Dr. Neirot, please turn on your microphone, Neirot. Turn on.
Microphone.
In the left, in down, left down. Okay, now it's okay, Neirot.
Dr. Coselli, I really enjoy your presentation.
Thank you.
Because in the early 60s, I made my first trip to Houston and spent 6 months there and had the possibility of witnessing what you had described. I mean, and during the scripture has been very accurate. I had the opportunity of seeing the rivalry between Cooley and DeBakey, and also the pleasure of seeing Dr. Crawford doing surgery. I mean, he was an extremely skillful individual, and that was a very important experience for me because eventually I became a pediatric cardiac surgeon, but still I cannot forget the 6 months that I spent in Houston. Thank you.
Oh, thank you.
Okay, Paulo.
Okay, Dr. Coselli, again, thank you for your fantastic speech or fantastic talk, demonstrating the pioneering spirit of bravery and innovation of the cardiovascular surgery. I hope that this lecture can demonstrate to young surgeons how long and tortuous this path was. And the example shown here will serve as inspiration for their professional and personal development.
Eu fico muito
Okay, thank you, Doctor.
Tinha vontade de...
Alô?
Ok, tem microfone aberto.
Ei, Helena, tá boa?
Fernando Lucchesi, fecha o microfone.
Não, é o meu? Não,
Não, pode falar sim. Já acabei de chamar.
Ok, desativei todos os microfones. Dr. Coselli, please, can you turn off your microphone, please? Okay, Enio, you can continue.
Turn on the microphone, Enio and Coselli.
Coselli, Dr. Coselli, your microphone it's down.
So it's
okay.
on now. I saw it.
Okay, it's okay. Enio, too, your microphone it's... No, you have to turn on your microphone, Enio.
Can you hear me now?
Yes, perfect. Thank you. Enio, não estamos te ouvindo, Enio. Teu microfone está... ok, agora está.
Okay.
Perfect.
Okay. Perhaps Dr. Vanderlei, our president, Dr. Coselli, could make the closing remarks. We thank you very much. I am sure that this was a remarkable conference. And we are very grateful to you for your friendship, and your lecture. You have a lot of friends and admirers in Brazil. You can be sure about that. I invite Dr. Vanderlei, that is our president, to make the closing remarks, and after that, you can say goodbye.
Ok, gente, muito obrigado a todos. Teve muita gente aqui da América, da Argentina, aqui participando desse evento. Um evento notável, casa cheia, né? Nós tivemos mais de 220 participantes. E agradecer ao professor Coselli, que nos deu essa história, que é uma verdadeira epopeia, né? E vamos convocar o Enio para preparar uma aula sobre a história da cirurgia da aorta aqui no Brasil. Então, boa noite, obrigado a todos. Thank you very much, professor Coselli.
Please, let's clap hands. Thank you very much, Dr. Coselli. You may say goodbye.
Thank you for this honor. I've really enjoyed it. Obrigado.
Okay, thank you.
Good night.
Good night.
Good evening.
Thank you, Dr. Coselli. Thank you again.